Öncelikle welcome. This is the last session of the day before the last day of the conference. We're all tired, and I hope it's not going to be boring for you. I'll be talking about a study that we conducted. I'm going to talk about glutamatergic dysfunction in the treatment of children and adolescents with trichotillomania. This is the outline of my presentation. First, definition and classification, and glutamatergic dysfunction and agents in OCB and associated disorders, topiramate, studies with topiramate, and our cases. We know that in DSM-4, trichotillomania was classified under impulse control disorders, and obsessive-compulsive disorder is under anxiety disorders. However, in DSM-5, obsessive-compulsive disorder is a main title now, and obsessive-compulsive disorder and associated disorders also cover trichotillomania, and also body dysmorphic disorder, hoarding disorder, and skin flocking disorder. I will be talking about the treatment of OCB and OCB-related disorders. In recent years, it was shown that in the pathophysiology of OCB and OCB-associated disorders, glutamatergic dysfunction may have a role, and glutamatergic agents might enable response in treatment. And we see that there are more and more studies in the literature now using these agents. While I was preparing this presentation, trichotillomania and glutamatergic dysfunction should be preceded by OCB and glutamatergic dysfunction, I thought. I mean, first I have to make a definition, and then, so I will talk about OCB and glutamatergic dysfunction, and then I'm going to proceed with a treatment. Neuroimaging, biochemical, and genetic studies show us that there is a glutamate problem in the pathophysiology of OCP. In magnetic resonance spectroscopy workup, we see that there is decreased glutamate concentration in the anterior cingulate cortex and caudate nucleus in OCB cases when compared with healthy controls. And in untreated OCB cases, we see that there is an increased level of glutamate in the brain spinal fluid, CSF, when compared with healthy controls. Because of these findings, in recent years, glutamatergic agents have been used in some studies for the treatment of OCB in adults and adolescents and children. What are these glutamatergic agents? Then roughly, the most frequent glutamatergic agents we see in studies are riluzole, amantadine, ketamine, topiramate, lamotrigine, and acetylcysteine, and D-cycloserine. There are some studies using cycloserine, but these are the most frequent agents used in studies. My colleague from Fırat University, Dr. Kemal Utku Yazıcı, collaborated with me on working these cases, and I would like to tell you how we came up with this study. Skin picking disorder was, I had a skin picking disorder case in my clinic. This patient used valproic acid, SSRIs, mood stabilizers, but none of these treatments were worked on her, and when she came to me, she was not using any psychological agents. Monoamines, dopamine, or other agents that might affect the secondary messengers pathways. These were not affected by the previous drugs. Therefore, we have done a literature screening, and we have seen glutamatergic agents and glutamatergic dysfunction information in the literature, and we decided to use NAC. We started NAC 600 milligrams, and we increased the dose in a controlled manner, and a couple of weeks later there was a significant improvement of skin picking. And we have used it for a treatment-resistant obsessive-compulsive case in acetylcysteine, and we augmented it. The patient was on 60 milligrams Stellopram, and we added NAC, and we started 600 milligrams NAC, and we went up to 2,400, and we have seen a considerable, significant improvement. And then we decided to make an open label study. We have filed an application with the ethics board, but the ethics board refused our proposal so quickly, and that is why we could not do an open label study. Therefore, we have conducted it in the form of case presentations. And this article is being revised at the Journal of Clinical Psychopharmacology, and I believe it is going to be published. We decided to work on trichotillomania as well, because we had so many trichotillomania patients. So we chose topiramate, one of the glutamatergic agents. We know that this is hair picking behavior that might result in hair loss, and it's a repetitive behavior. In the past, it was thought that this was a rare condition. It was not in the psychiatry literature for long years, but then the research showed that the incidence is higher than known, and 0.6 to 3.5% of the child and adolescent population was affected. When it starts that the childhood response to treatment is better, in adolescence, when the onset is during adolescence, the clinical manifestations are more severe. In most of the psychiatric disorders, the prognosis of early onset disorders is worse, actually. However, here the researchers have shown that early onset trichotillomania cases have a better prognosis, whereas the late onset ones have a better prognosis. There is not a common treatment algorithm for trichotillomania, BCT, or alone or in combination with psychopharmacological agents is a standard therapy. SSRI or clomipramine are the most common agents in psychopharmacology. However, there are still controversial issues, and the improvement is not as desired. If there is insufficiency of pharmacological treatment, typical or atypical antipsychotics, lithium, bupropion, and naltrexone were used, and some studies show some benefit of these drugs. However, the desired improvement cannot be achieved with these drugs in many trichotillomania cases. So we need new treatment options. So we decided to use topiramate. Topiramate was synthesized first in 1979. It was first used in the UK in 1995. In 1996, adolescents and children between the ages of 2 to 16 could use it for the treatment of tonic-clonic seizures as approved by FDA. If it's an anti-epileptic, but it is used for the treatment of some other diseases. It blocks the voltage-sensitive sodium and calcium channels, and it also increases GABA activity in a dose-dependent manner. In the GABA receptor complex, it has an impact on the binding point, on another binding point than benzodiazepine binding point, and AMPA receptors are selectively antagonized by topiramate, and it also inhibits the enzyme. OCB and OCB-associated disorders have a certain, it is prone to certain types of treatment, and AMPA-glutamate receptors, when they are inhibited in the extracellular area, glutamate concentration is reduced. Therefore, it is used for the treatment of OCB and OCB-associated diseases. When we look at the literature and the studies using topiramate, we see 3 randomized control trials. The newest one is in 2014 by Afshar and co-workers. 38 adult patients with OCB who did not respond to SSRI underwent topiramate augmentation for 12 weeks. In the first 8 weeks, the total scores improved, but then this significant improvement goes away at week 11. Movla and co-workers also carried out a randomized control trial in 2010. 49 patients with OCB who did not respond to SSRI underwent topiramate augmentation of 12 weeks, and Y-box total scores improved. And in 2011, in another RCT, 36 patients, 12 weeks of topiramate augmentation, compulsion subscale scores improved. However, there was no significant improvement in obsession scores. And in the literature, there are 2 open-label studies and 1 case presentation. 3 of them were published in 2006, and in all 3 of them, topiramate augmentation results in a significant response. And when we look at the topiramate literature, we have only seen 1 open-label study in 2006 by Lochner and co-workers. This is the only study looking at the effect of topiramate on trichotillomania. 14 patients, open-label follow-up for 16 weeks with topiramate monotherapy. 9 patients completed the study. 5 patients dropped out because of side effects. The most common side effects were paresthesis, speech difficulty, and increased anxiety. Massachusetts General Hospital hair pulling scale scores were significantly decreased together with the use of topiramate in this study. In the literature, there is no other study using topiramate for trichotillomania, and that the only study was on adults. We did not see any study for children or adolescents, and we were curious of topiramate augmentation. That is why we designed a study, but the ethics board did not approve it, and that is why we decided to draft our article in the form of a case series. And 6 patients are involved in this study. Systemic examination, routine hemogram and biochemical tests were performed, and habit reversal therapy was used for each patient. If habit reversal therapy was used before the patient came to our center, we did not repeat it, but if not, we used the habit reversal therapy. Massachusetts General Hospital hair pulling scale was used to measure the hair pulling behavior. We also used CDI for depression level, and back anxiety scale for anxiety levels. Clinical global impression scale was also used. The starting dose for topiramate was 25 milligrams per day, and we increased the dose every 2 weeks. The maximum topiramate dose was 200 milligrams per day, and for 6 months the patients were evaluated with an interval of 4 weeks, and primarily we looked at the clinical status of the patient in evaluating response to treatment, and we also looked at the changes in the Massachusetts score and CGIS scores. We had 6 cases, and 2 of them had comorbid anxiety disorder as well. 1 patient had medical epilepsy, and 1 patient was obese. 4 out of these 6 patients benefited significantly from topiramate augmentation. However, we have not seen any improvement in 2 cases, and we also have seen irregular appetite, which did not result in any weight alteration, but we thought it was caused by topiramate. This is a complicated table, but look at the 3rd and 4th cases here. These cases were the ones who did not benefit from topiramate augmentation. The other 4 benefited from topiramate augmentation. In cases 3 and 4, you see they're both 16 years old, and they're both males, and relatively they're older than the other cases. In the beginning, I said that late onset trichotillomania cases have a worse prognosis. So 16 years old, older than the others, and both patients had anxiety disorder. And patient number 3, in addition, had epilepsy. We try to interpret it as follows in our discussion. In these cases, whom we thought did not respond to topiramate augmentation had psychiatric comorbid diseases, and they were relatively older. And these might be correlated with lack of response to treatment, but this should be studied further. And our study is the first study in the literature as regards the use of topiramate in children and adolescents for trichotillomania. So it is important therefore to attract the attention to the fact that there are no studies in the literature. It's still April, therefore I would like to remind you of autism awareness, and thank you very much for your patience.